Press 2 fingers into your lower shin, just above the ankle, hold them there for 5 seconds, and release. If the indentation stays, if the skin holds the shape of your fingers for even a moment before slowly rising back, you are already holding this entire argument in your hand. More than 300 million people worldwide live with chronic venous or lymphatic insufficiency, and the average patient waits between 8 and 12 years before receiving a correct diagnosis. 8 to 12 years of being told it is normal aging, too much salt, not enough walking. That dent you just made in your own leg has a clinical name, a documented biological cause, and your doctor has never once tested for it. The diagnostic incentive structure of modern medicine made sure you never learned the real cause. By the end of this video, you will know exactly why leg swelling became a symptom to suppress rather than a system to restore, and the specific steps you can take starting today. Subscribe so you never miss what the medical establishment hopes you never ask about. To understand how this was buried, you have to go back to 1622, to a dissection table in Padua, and a man named Gasparo Uccelli. Uccelli was an Italian anatomist performing a vivisection on a recently fed dog when he noticed something no one had formally recorded before: a network of fine vessels running through the mesentery, the tissue that anchors the intestines, pulsing with a milky white fluid that moved with direction and purpose. These were the lacteals, the gut branch of the lymphatic network, and what Uccelli had stumbled onto was the body's secondary circulatory highway, the system that collects the fluid leaking from your capillaries into your tissues every second of every day, filters it through hundreds of lymph nodes, and returns it to your blood. The thoracic duct, the body's primary lymphatic collecting vessel running from the abdomen to the subclavian vein near your collarbone, handles somewhere between 2 and 3 liters of this interstitial fluid every single day. 2 to 3 liters, every day, without a pump, without a heartbeat driving it, without a single pharmaceutical molecule required to keep it moving. Uccelli's discovery was published posthumously in 1627 in a work later referenced as De lactibus sive lactae venous, and medicine filed it away as an anatomical curiosity rather than a clinical imperative. A 17th-century Italian anatomist found the body's waste removal highway, and medicine spent the next 4 centuries building a superhighway directly over it. In 1647, the French anatomist Jean Piquet traced the lymphatic network further, documenting the cisterna chyli, the abdominal reservoir where lymph collects before entering the thoracic duct, and confirming the connection to venous circulation at the subclavian vein. The system was mapped, the mechanism was documented, and then, in 1628, William Harvey published De motu cordis, and the entire medical world pivoted to the heart, the blood, the pump, the circulation that could be felt through the wrist and heard through a stethoscope. The lymphatic system, which moves more fluid volume than the venous return system in the lower extremities, became the quiet parallel network that every anatomist knew existed and almost no clinician learned to treat. Here is the first twist, and it is the one that changes everything. The biological principle behind your swollen legs is not new, not disputed, not experimental. It is 400 years old, thoroughly documented, anatomically mapped in every medical atlas from Vesalius onward, and clinically proven to respond to interventions so simple they require no prescription pad. The body built its own waste removal system long before the first pharmaceutical company. It does not need a drug, it needs conditions. The lymphatic system has no central pump. It moves fluid through muscular contraction, diaphragmatic breathing, postural change, and the rhythmic compression of body movement. The vessels themselves, the lymphangions, are segmented chambers with one-way valves that contract 6 to 10 times per minute under normal conditions, propelling fluid upward against gravity toward the thoracic duct. In the lower legs, those vessels are the farthest from the drainage endpoint. Gravity pulls 2 to 3 liters of capillary filtrate into lower extremity tissues every day. If the valves weaken, if the vessels become insufficient, if the surrounding musculature stops providing the compression those vessels depend on, the fluid stalls. Proteins that would normally be cleared begin to concentrate in the interstitial space. The tissue thickens. The skin tightens. The indentation that stays in your ankle after finger pressure is called pitting edema stage 1, lymphatic insufficiency and left unaddressed. Clinical observations from multiple staging systems document a progressive path toward fibrotic edema, a harder, non-pitting stage where the tissue has begun to scar from the inside. The indentation in your leg is stage 1. Stage 3 does not indent anymore. it has turned to stone. In the 1930s, a Danish physiotherapist named Emil Vader was working with patients whose lymph nodes had been chronically swollen patients, dismissed by conventional practice as simply congested or immune-compromised when he began. Applying a technique of light, rhythmic, directional skin pressure along the known pathways of lymphatic drainage. What Vader documented over years of clinical observation was this: lymphangian contraction could be externally stimulated. Fluid that had stalled in peripheral tissues could be manually encouraged back into the collecting vessels, and the sensation in the treated limb, the warmth, the lightness, the reduction in that tight, pressurized feeling beneath the skin appeared within 20 to 40 minutes of treatment. Manual lymphatic drainage, the technique Vader developed, was not based on theory. It was based on observable, repeatable clinical outcomes. A Danish physiotherapist in the 1930s had already found the answer your doctor never mentioned. The question is, why it disappeared. A woman I will call Margaret walked into my practice after 11 doctors in 8 years. Her ankles were swollen every evening, worst by 6 or 7 in the evening, reduced by morning after a night of horizontal rest. She had been prescribed diuretics, compression stockings, and a salt-restricted diet. No one had ever examined her lymphatic drainage pattern. No one had palpated her inguinal nodes. No one had traced the pattern of her swelling above the ankle to assess whether it was gravity-dependent or indicative of proximal obstruction. She was being managed. She was not being diagnosed. In a functioning lower extremity lymphatic system, the inguinal nodes, the cluster of lymph nodes in the groin, receive drainage from the leg's collecting vessels, filter the fluid, and pass it upward to the pelvic and abdominal lymph nodes before it reaches the thoracic duct. The time of day pattern Margaret experienced worse by evening, reduced by morning, is the clinical signature of gravity-dependent drainage failure. The system cannot overcome the hydrostatic pressure of 6 to 8 hours of upright posture. The fluid pools. By morning, lying flat, partial passive drainage occurs. The cycle repeats. The International Society of Lymphology has published staging criteria that describe this progression in precise clinical terms, and those criteria exist in peer-reviewed literature. Most general practitioners see pitting ankle edema and reach for a prescription pad before those criteria are ever consulted. Now here is what makes this story broader than your ankles. In 2013, Dr. Macon Nadergaard and her team at the University of Rochester published findings in the journal Science that described a previously unmapped brain drainage network they named the glymphatic system. During deep, non-REM sleep, glial cells in the brain shrink by approximately 60%, opening channels through which cerebrospinal fluid flushes the interstitial space of the brain, clearing metabolic waste products including amyloid beta and tau proteins, the same proteins that accumulate in neurodegenerative disease. This clearance does not happen during waking hours. It does not happen in light sleep. It happens specifically during deep sleep, and the cleared waste drains into cervical lymph nodes before entering venous circulation. The same system draining your ankles is draining your brain. Your doctor treats them as separate problems. The body does not. This is where the story requires you to identify yourself. Because here is the number that changes everything about what comes next. There are not 1 but 3 distinct clinical presentations of lymphatic insufficiency in the lower extremities, and treating the wrong one does not simply fail, it actively makes the underlying condition worse. Type 1 is gravity-dependent edema. Swelling that appears in the ankles and lower legs by late afternoon, resolves with overnight horizontal rest, pits clearly with finger pressure, and is associated with prolonged standing or sitting. The root is primary lymphatic insufficiency, or chronic venous hypertension with secondary lymphatic overload. Type 1 responds well to compression therapy and elevation, and manual lymphatic drainage is most immediately effective here. Type 2 is whole limb or unilateral swelling. One leg swells more than the other, or the swelling extends above the ankle toward the knee or inner thigh, does not fully resolve overnight, and the skin along the inner thigh may feel firm or rope-like under the fingers. The root is lymph node compromise post-surgical, post-infectious, or structural obstruction. Here is the critical differentiator. Applying compression to a type 2 limb without first clearing the proximal nodes with manual drainage pushes fluid against a blockage and worsens congestion above it. Type 3 is systemic swelling with fatigue and brain fog. leg swelling accompanied by persistent morning puffiness in the face or hands, cognitive cloudiness that arrives by mid-morning, recurring minor infections, and fatigue disproportionate to activity. The root is systemic lymphatic insufficiency, often with autoimmune or thyroid involvement. Standard edema protocols address only the peripheral symptom. In type 3, the drainage system from the gut, the mesenteric lymphatics, which carry a substantial portion of dietary fat and immune signaling through the lacteals, Acelli first observed must be addressed before peripheral protocols are effective. Identified your type? Keep it in mind. Because what I am about to tell you only applies if you know which category you are in and what helps one type actively worsens another. 3 types. 1 misdiagnosis umbrella. That umbrella has a brand name, water retention. In the years following the Second World War, the pharmaceutical industry expanded its reimbursable diagnostic categories with remarkable efficiency. Thiazide diuretics received regulatory approval in the late 1950s. Loop diuretics followed. A physician with a patient complaining of swollen ankles now had a billable 10-minute appointment, a reimbursable prescription, and a measurable short-term result. The kidneys excreted water, the swelling reduced, the patient returned. What the diuretics could not do, was restore lymphatic valve function, clear interstitial protein accumulation, or address the underlying drainage insufficiency. In type 2 lymphedema specifically, clinical observations document that diuretic use without concurrent lymphatic drainage concentrates the proteins stranded in the interstitial space because the water is removed while the proteins remain, accelerating the fibrotic process that eventually makes the tissue non-pitting. The diagnostic code system had no primary care billing entry for lymphatic insufficiency. The insurance reimbursement structure paid for the prescription, not the drainage therapy. The GP had no tests to order and no time to investigate. Your doctor did not choose the wrong treatment because he was careless. He chose it because it was the only one the system was designed to offer him. My name is Dr. James Whitfield. I served as a clinician in lymphatic and vascular medicine for more than 22 years. I am telling you this now because what I watched happen to patients during those 2 decades should not happen to you. And here is twist 2. The disappearance of lymphatic root cause medicine from standard care is not a conspiracy. It requires no boardroom, no deliberate suppression, no coordinated plan. It is the aggregate outcome of 4 structural facts operating simultaneously. American medical schools dedicate, by multiple curriculum audits, fewer than 10 hours across 4 years of training to lymphatic medicine, a system that moves more fluid than the venous return network in the lower extremities. The NIH has historically allocated a fraction of cardiovascular research funding to lymphatic research. The ICD-10 diagnostic code architecture distinguishes lymphedema as a specialist diagnosis while coding general edema in a way that routes it toward pharmaceutical management rather than lymphatic assessment. And no pharmaceutical company holds a patent on elevating your legs, breathing diaphragmatically, or having a certified therapist manually stimulate your lymphangins. Root cause restoration has no molecule. Symptom suppression has a reorder rate. The lymphatic system was not disproven by science. It was made economically inconvenient to investigate. The system works exactly as it was built to work. A retired schoolteacher, a man in his early 60s, who had been prescribed diuretics for 7 years, came through the practice after experiencing progressive tightness in his right calf that had never fully responded to any intervention. Ultrasound had cleared him of deep vein thrombosis. Cardiac workup was unremarkable. He had been told the swelling was idiopathic. What imaging of his lymphatic drainage pattern revealed was a specific failure in the collecting vessels above the right knee, a pattern consistent with a lymphatic insufficiency that had been quietly progressing since a prior infection years earlier. Proximal clearance of the inguinal and pelvic nodes, followed by graduated distal compression therapy, produced measurable limb volume reduction within 4 weeks of beginning treatment. The indentation stopped appearing in his right ankle by the end of the first month. What makes this truly remarkable is that the technology to see this in real time now exists and has existed for years. Near-infrared fluorescence imaging using indocyanine green ICG lymphography allows clinicians to visualize lymphatic flow in living tissue, to watch the fluid move, to see the valves function or fail, to map exactly where the backflow begins and the stagnation pools. This technology is in clinical use at specialist centers. It has been documented in peer-reviewed lymphology literature, and it has never been offered as a standard diagnostic option to the general practitioner, managing the millions of patients presenting each year with swollen legs and a diuretic prescription. The research is not hidden in some foreign laboratory. It is sitting in the NIH database. It has been cited in peer-reviewed American journals, and it has still never been translated into a conversation your doctor has had with you. Now here is what other healthcare systems did with the same evidence. In Germany, Austria, and Scandinavia, complete decongestive therapy, the structured clinical protocol combining manual lymphatic drainage, compression bandaging, therapeutic exercise, and skin care, is a funded, standardized treatment pathway for lymphatic insufficiency. The Foldi Clinic in Hinterzarten, Germany, established by Dr. Michael Foldi and his colleagues, has operated as a clinical center for lymphatic medicine since the 1970s, training therapists, documenting patient cohorts, and publishing outcome data that describes measurable limb volume reductions in chronic lymphedema cases, reductions in cellulitis episodes, a common and serious complication of untreated lymphedema, and documented quality of life improvements across patients monitored over years. The International Society of Lymphology has published consensus documents on evidence-based lymphedema management since 1995. Those documents exist in PubMed. They are not behind a paywall. They are not classified. They are simply not referenced by any diagnostic pathway the viewer's general practitioner was trained to follow. In Germany, it is a prescription. In America, it is a spa treatment. The lymph fluid does not know the difference, and this is the part the diagnostic industry cannot explain away. The biology has not changed. The three-type protocol that research supports is not experimental. For type 1, diaphragmatic breathing stimulates thoracic duct flow by creating negative pressure in the chest cavity that draws lymph upward. Leg elevation above heart level uses gravity to assist the return the lymphangians cannot accomplish alone. Graduated compression at 20 to 30 millimeters of mercury supports the vessel walls against the hydrostatic pressure of upright posture, and calf pump exercise, simple ankle flexion and extension, provides the muscular compression the lymphangians depend on. For type 2, the clinical evidence documents that a certified lymphedema therapist performing proximal clearance before any distal compression is applied prevents the worsening that compression alone produces. For type 3, sleep optimization for lymphatic clearance, gut motility support to maintain the mesenteric lymphatic pathway, and concurrent thyroid and autoimmune screening are documented as necessary parallel interventions. Every one of these approaches is available to you today. None require a prescription. None generate a reorder rate. None appear on a standard 10-minute appointment checklist. In 22 years of treating patients whose lymphatic systems had been failing silently for a decade before they reached my door, I never once saw a case that did not respond at least partially to the same biological principles documented in the literature since 1622. The biology has not changed since Aselli stood at that dissection table in Padua. The thoracic duct is still doing what he first observed: contracting, propelling, filtering, returning fluid to circulation through vessels finer than a strand of hair, passing it through somewhere between 600 and 700 lymph nodes distributed across your body, none of which your doctor has ever palpated in the context of your swollen legs. Lymphedema remains among the most underdiagnosed chronic conditions on the planet, affecting hundreds of millions of people globally, the majority of whom have never heard the word spoken in a clinical context that applied to them. Press your fingers into that shin again. The indentation that stayed that is not a mystery anymore. That is a system asking for conditions it has always needed, in a language medicine spent 4 centuries learning to ignore. Subscribe. The body has been keeping its own records far longer than the diagnostic system has been keeping yours. This content is for educational purposes only and does not constitute medical advice. Always consult your physician before making changes to your health routine.